Good morning, everyone. Good morning, faculties and delegates. This is Chitrakala from Shield Healthcare. I welcome everyone on behalf of Shield. Today, we are going to have a webinar with SCALE. SCALE is a Sri Chakra Academy of Learning and Education in Fertility, conducted by Dr. Vasantra ma'am. We cordially invite you for this webinar. Today, our topic is psychological challenges during IVF and what are the risks and management. Before going into the session, we will start the webinar with Ganesh Vandana.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
So we will start the session by introduction of Dr. Vasantra ma'am. I request Mr. Balaji sir to introduce Vasantra ma'am.
Good morning, everybody. It's a great pleasure for us from Shield to be a part of this very interesting and useful webinar today. I have the great privilege of introducing Vasundhara Madam. Dr. Vasundhara Madam has done her MBBS from Belgaum. She is a gold medalist in DGO from SRMC and Apollo Hospitals. And she is trained in ART from National University Singapore and University of Kiel, Germany. Doctor is a professor in OB-GYN department at Railway Hospital for DNB postgraduates. And the most important thing is the initiative what we are seeing today from SCALE. She is the founder of SCALE, which is here to continue and pursue its education and knowledge sharing for all the doctors across. Dr. Vasundhara has made a lot of paper presentations in various national and international forums. And her areas of interest is recurrent implantation failure and genetics and fertility preservation. Dr. Vasundhara is affiliated to life membership in ISAR, IFF, SRA, ASRM, and ASPIRE, and she is a life member of OXY and IMA also. Dr. Vasundhara Madam, we are here from Shield to support all your endeavors in making this scale to scale up. And over to you, Madam. Thank you.
Very good morning, and thank you, Mr. Balaji sir. Very humble and very respectable person, President of Shield, to have I have the honor to get introduced by you, and Chitra for coordinating the entire webinar. It is indeed my pleasure to be a part of this webinar, and today's webinar is a special one because we have a guest speaker with us. And the topic of this webinar, psychological challenges in fertility, has been chosen because I feel over the years, more than 20 years into this field, I feel that psychological stress and psychological aspects are less addressed, and people have the inhibition to ask for psychological help, though that takes a major toll in all our fertility patients. So today, over the next 40 minutes, myself and the guest speaker, Ms. Purnima, will be discussing and dwelling upon these aspects of psychological care which we need to address for our fertility patients so that their fertility treatment journey is very smooth without much of mental health issues. And without much ado, I would like to move over to the topic of discussion today. I'll just share my screen. Is my screen visible?
Yes, ma'am.
So, psychological care is defined as a care that enables the couples, their families, and their healthcare providers to optimize fertility care and manage their psychological and also associated social implications of fertility, infertility, and its treatment. It is very important because most of our patients experience emotional distress during treatment, and around 36 to 37% discontinue their treatment prematurely because of the perceived burden of the treatment. One third of our patients end treatment without achieving pregnancy and also experience difficulties in adjusting to their unmet parenthood goals. Now, what are the reasons for dropout of fertility treatments? Emotional and psychological stress, demographic and personal reasons, financial burden, especially in Indian scenario where many of the fertility treatments are not funded by insurance programs, interpersonal relationship issues, physical discomfort, fertility clinic related discomfort, pregnancy related factors. Now, what are the high risk factors in our patients which would prompt us that that they might require psychological help? These are those clients who are lower in their educational status, both men and women, pre-existing mental health disorders, multiple IVF failures, older women embarking on fertility treatment, when they have to adopt to a donor gamete cycle, whether it is donor sperm, donor eggs, or embryo adoption, or opting for gestational surrogacy, they are at high risk for psychological adaptation to the entire process, and we should definitely keep these three patients in our mind, and definitely when there is an associated male factor in fertility issues. Now, what are the indications for referral for psychological counseling? Now, indications are anywhere even before starting the fertility treatment, during and after. So this has to be segregated into three different aspects: before, during, and after fertility treatment. Whether it is involving a basic step like ovulation induction and the timed intercourse, or patient is embarking into an assisted reproduction like IVF or ICSI. Many times we have even seen couple just coming for first consultation. They just want to know if everything is normal, but then in their first consultation we know that there is some relationship issues. They ask for psychological help before even starting their sexual life or fertility journey. So it is as basic as before starting the treatment to during the treatment and after the treatment process. Sexual dysfunction, whether it is a male sexual dysfunction or whether there is a female sexual dysfunction, especially in a couple where there is a requirement for fertility preservation, wherein the male or the female should preserve their fertility in view of their pre-existing medical disorders like malignancy, etc. Whenever a single parent or one spouse wants to reproduce while separating from the spouse. So these are definite indications for referral to psychological counseling. Divorced or divorcing patients who jointly own their embryos in storage, third party reproduction, as I mentioned, whether it's donor eggs, donor sperms, embryo adoption, or gestational surrogacy. Then there is LGBTQ couple and their right to be a parent, legal adoption, and again, finally, most of us should important the most important thing is when the patient has to end their fertility treatment, further follow up and psychological counseling is definitely mandatory. Now, are there any tools to detect the needs of our patients? There are a lot of tools which is available. Indian tools to assess is this PGI healthcare questionnaire form or PGI well-being scale, wherein it assesses the levels of the distress that refers to non-specific symptoms of stress, anxiety, feelings of worry, sadness, and depression. There's also the tool called Screen IVF tool, which is by the ASRM, is an infertility specific validated tool designed to be used before the start of treatment to assess the risk factors for emotional problems after a treatment cycle. Now, whenever there is a gestational carrier, what is the role of mental health in these individuals? And are there any psychological screening limitations is what we have to understand. So these screening tools, what it can tell us is, first of all, whether it meets with certain standard guidelines like ASRM or ISHRAE, if she is deliberately trying to look good or not, presence or absence of psychological pathology, and personality factors and coping up styles can be assessed by these tools. But what it cannot really tell is whether they have any relationship issues, whether there is a guarantee of a problem-free surrogacy, whether her feelings and beliefs today will remain throughout her treatment cycle until she hands over the baby to the biological parents. So there are a lot of aspects, mental aspects, and adjustment aspects of the gestational career during this whole process. There could be other process related issues where the couple need to undergo urgent treatment. So again, we might have less time for the couple to prepare them psychologically to enter the treatment, and also accessibility to the professional. Like, sorry, in India, the accessibility to professional psychological counseling is limited, and we need to create more and more awareness that there is availability of definite expert professional care, and we need to encourage the couple to have accessibility to psychological counseling. Now, care of intended parents and gamete donors, the ASRM recommendation is definitely there should be a psychological counseling that has to be imparted in all of these intended parents as well as donors, amongst the list of other things which is recommended. Now, this is a wonderful guideline. I am going to just summarize a few important points from the ESHRE guidelines. Routine psychological care in infertility and medically assisted reproduction. This is a guide for the fertility staff. So it is not only the doctor, the entire fertility team, be it the counselor, whether it is a financial counselor, whether it's a staff fertility nurse who is going to give routine injections to the patients. Lot of people are involved in the success journey or in the failure journey of the patient. So every staff member in the team is important to understand about the psychological care in infertility. These guidelines describes patient's needs, informs about the risk factor for specific psychosocial needs, and tools to detect these problems. It also lists the evidence-based psychosocial interventions that can be delivered by the members of the staff without specialized training in mental health care and do not require active intervention of mental health professionals, example, specialist counselors, psychologists, psychiatrists. By this we mean, at least we need to be aware, the fertility staff need to be aware and about what psychological needs our patients really require, and we can also triage these the patients who will need expert care at a very basic level in the center. Conditions assumed necessary for patients to have a healthy experience of fertility treatment include, first of all, needs can be behavioral. They can be lifestyle factors, exercise, nutrition, and compliance problems. Relational, relationship with the partner, family, friends, and larger network and work. Especially, in Indian scenario, it becomes very difficult for the couple who are not having a baby to even go for any functions, because most of the times many of the relatives or friends will just give additional advice of why you're not getting pregnant, go meet this doctor, and they're really having a taboo to even attend a function. So there could be a lot of issues for which our couples face during this journey. Emotional, again, anxiety, depression, and quality of life, and cognitive like treatment concerns and knowledge. So these are the various things you have to segregate and understand from our patients. Even when a pregnancy is achieved through a fertility treatment, it is experienced with increased anxiety about the viability and the health of the fetus. So whenever they are conceiving out of a fertility treatment, they're more anxious as to how the outcome is going to be, how each phase is going to be. They want more, frequent consultations and reassurance from the doctor as well as the team that the pregnancy will be smooth. By offering psychosocial care in combination with medical care during the routine practice, fertility clinic staff can ensure that care is accessible for all patients and addresses their most common needs. So this is a beautiful, chart which we can, have wherein, it addresses the behavioral, relationship and social and emotional and cognitive needs of our patients. It can be as early as before treatment starts from the diagnosis part, from the during the treatment and after the treatment, be it successful or unsuccessful. Now, what are the patient's preferences and well-being? So, which aspects and components of psychosocial care are really important to the patients? The GDG recommends fertility staff should be aware that patients expressing a need for emotional support value the offer of specialized psychosocial care like infertility counseling or psychotherapy. Patients may also value the presence of a chaperone during the medical examination, and men definitely value designated private rooms for sperm sample collection. Which routine psychosocial care components are important to patients? Again, fertility staff definitely should be aware that IVF patients equally prefer in-person or telephone consultations to discuss their treatment results and future plans. So we always make it mandatory whenever they have undergone a treatment, be it an IUI or an IVF, and when they are due for a result, we as clinicians are available because we are waiting anxiously to know whether the treatment has really worked out or not. And it is our duty to provide the result at an appropriate time. And as a clinician, we should ensure that we are able to connect with them and talk to them on the day when the result is available. This is very, very important for their emotional well-being. Provision of information about psychosocial care options, example, contact details of certain support groups, online support groups, or access to infertility counseling or psychotherapy is very important. Now, what are the characteristics of fertility staff and clinics that are associated with patients' well-being? One is tailored online psycho-educational interventions may improve infertility-specific stress and self-efficacy and the sexual and social concerns of particular groups of patients. Now let us dwell into before, during, and after treatment. So the before treatment period refers to the period that begins at the first visit to the clinic until the start of the first treatment cycle, being it either first line treatment such as IUI or ovulation induction or assisted reproductive treatment. 1 in 10 do not want to begin their fertility treatment at all. And what could be the reasons? Reasons is rejection of treatment due to ethical objections, concerns about and lack of interest in the treatment, personal reasons, relationship problems, financial issues, and psychological burden of the treatment. So 1 in 10 don't even want to begin their fertility treatment due to the following reasons. Now, how can fertility staff detect the needs of the patient before treatment? So, it is recommended to offer patients the opportunity to have their needs assessed and be informed about their emotional adjustments before the start of the treatment. It is also recommended that the fertility staff consider explicitly screening risk factors, example, drug abuse, eating disorders, sleeping disorders, for as a reason for decreased fertility in these patients. Now, what are the relational and social needs? We should be aware that women experience higher social and sexual infertility specific stress than men. And with regards to emotional needs, women have a higher levels of depression and infertility stress than men. Women whose partner has male factor infertility experience higher anxiety than women with female factor mixed or unexplained infertility. In couples, each partner's depressive symptoms are associated with their own and their partner specific infertility distress. It is recommended that fertility staff use certain screening tools before the start of each treatment cycle to assess the patient's risk factor for their emotional problems after the cycle begins. How can fertility staff address the needs of the patients before the treatment? So we need to look at whether the patients are experiencing any risk factors or psychosocial problems, and then their behavioral needs should be assessed. They should be prepared with certain information about the medical procedures because it promotes better compliance. So we need to tell them what this procedure involves, whether it is a painful process, whether it is involving an anesthesia or not, how they should come prepared before the procedure. So all these should be explained to the patients so that they are compliant to the treatment. Now, during the treatment period refers to the time that encompasses any treatment cycle, being either the first line treatment such as IUI or ART. So, behavioral needs, the reasons patients take for discontinuing recommended first line of treatment are postponement of treatment, that is, stopping treatment for at least 1 year, logistics and practical reasons, rejection of treatment, perception of poor prognosis, and psychological burden of the treatment. Now, also women report lower social support from significant others in the period between oocyte retrieval and embryo transfer cycle than during the equivalent period in a normal menstrual cycle. Loss of work hours, it's very important, and intimacy with the partner during the treatment process. So all this needs to be looked into. Patients are into a lot of emotional stress, and it fluctuates during the treatment cycle with peaks at oocyte retrieval, the embryo transfer, and the waiting period before the pregnancy test. So once the embryo transfer is done, and they're given a waiting period for 2 weeks for their beta HCG to be, known, this 2 weeks wait period is extremely anxious for the woman and also the entire family, and their emotional stress level fluctuates until the result. We need to address this period and give them maximum emotional and psychological support. After receiving the pregnancy test for their IVF or XC treatment, 1 in 4 women and 1 in 10 women can have depressive disorders, and 1 in 7 and 1 in 20 men have an anxiety disorder. So we need to actually look into the seriousness and core of this problem. Patients with previous history of vulnerability to mental health disorders are more likely to experience depression, anxiety, and or psychiatric morbidity during treatment. So how can we address as fertility staff the needs during the treatment cycle? It is recommended that fertility staff refer patients at risk of experiencing clinically significant psychological problems to specialized psychosocial care, be it infertility counseling or psychotherapy. Now, the after treatment period, this refers to the period starting 1 year after patients undergo their last treatment cycle, and the section differentiates between people who did not conceive with treatment, that is an unsuccessful cycle, and people who did, that is successful treatment that results in live birth. So we should be aware that women who conceive with IVF and ICSI may experience more pregnancy-specific anxiety than women who conceived spontaneously or naturally. Also, women with multiple pregnancies after IVF or ICSI may have higher maternal expectation than women with spontaneous multiple pregnancies, and also the staff should be aware that former patients who remain childless for 5 years or later after an unsuccessful ART treatment may use more sleeping pills, smoke more often, or consume more alcohol than former patients that became parents via adoption or spontaneously conceived. So these things should be kept in mind for couple after treatment process. So how can we address these needs of the patient after treatment? We should refer patients when ending unsuccessful treatment are at risk of experiencing, whether it's short or long-term clinically significant psychological problems, to specialized psychosocial care. And we should also offer patients the opportunity to discuss the implications of ending unsuccessful treatment. So we also have to look at giving them routine and continuous care. This should be a client-centered approach. Empathy and clear communication is very, very vital. Individualized treatment plans, setting realistic expectations, and counseling appropriate success rates. So we cannot really counsel the couple that you undergo an IVF treatment, that is the end of a fertility journey, and once you do the treatment it is 90% successful, it's 95% successful. We have to keep their expectations grounded. We all know the live birth rates following IVF or XC is close to 35% to 40% worldwide. So we need to set their expectations right even during the routine and continuous care of these patients. We need to reinforce this again and again to the couple. Involving both partners in decision making is extremely vital. Detection of high risk individuals who need specialized care is also important. Now, regarding specific treatments that can be once they refer to a professional for psychological treatment, they can be assessed and put into any of these bracket of treatments like cognitive behavioral therapy, acceptance and commitment therapy, mind body therapy, and meditation and yoga can also be undergone along with all of any of the above therapy. Now, what is psychological care after successful treatment? So patients are happy, but then when there is a multiple pregnancy, there is more stress and anxiety, increased risk of postpartum depression. Psychological care should be ongoing with ART pregnancy. Now again, we also have to look at the most important part. What is the care in an unsuccessful cycle? So management before the cycle starts to prepare the couple for failure is extremely important. So setting up a realistic success rates is extremely vital. Treatment planning, need for multiple cycles to increase the cumulative success rates is very, very important. Management of patients when cycle fails is tackling the conflict and regret. Men needs counseling as well. So it is not only the women, it has to be the couple, and men also needs to be involved once the cycle is unsuccessful. So what about end of treatment care? Couple who quit treatment after unsuccessful cycle need special psychological care. Follow-up beyond 1 year is very much recommended. Acceptance, make them accept. That is only done by making meaningful and pursuing alternative goals we should be able to suggest to them. special care for those planning adoption should be given. Long-term management of patients who fail treatment, as we discussed, there can be, psychiatric disorders in 10% of women and 30% of men. Engaging in other hobbies like, pets or, caring for pets or traveling, career or caring for other people should be, explained to the couple. Acceptance of failure becomes easier if they are reassured and assured that all treatments which are evidence-based have been attempted and all the opinions are clearly explained and they are ensured that they have received the best medical advice, then they are more, accept the failure. And also, if the acceptance is better if they have an identified reason for their failures. So to conclude, patients have clear preferences about their care they receive. Fertility staff should know these preferences and incorporate them in their service delivery to the patients. Staff must inform themselves of specific needs patients experience at different treatment stages, whether it is before, during, or after, and tailor psychosocial care accordingly. And some patients are more vulnerable to the demands of treatments and need additional psychosocial care or specialized mental health services like psychotherapy or infertility counseling. The most effective way to start implementing psychosocial care is by providing preparatory information because it is expected to be simpler and more feasible to implement compared with other reviewed interventions and shown to be efficacious in addressing many patients' needs. Thank you so much for this opportunity. I would like to take any questions which is there at the end of this session. Thank you so much.
Hi, Dr. Vasundhara. So it was really nice hearing you about the psychosocial care. So as a psychologist, I was just curious to understand that what is the prevalence rate in terms of like how many patients that you see in OPD that you end up referring out for psychotherapy or who have psychological concerns?
I think we need to do a critical analysis about it. This is very important if we have some like screening tool which we teach our staff and it should be Indianized. We cannot extrapolate everything to the Western world because there are certain lifestyle factors which are not still prevalent here. And given this awareness and circumstances, like in the Western world, they directly go and seek help for mental health and they take it very seriously. Mental health is equally important like your physical health like hypertension, diabetes, and other things. So they seek psychiatric or psychological professional help there in the Western world. Even though I see many of our fertility clients do require this, their acceptance is still not that much. And when, as a clinician, when I suggest to them, some people take it very seriously and they would want to do it. Some people would say that I don't have a mental disorder. They become more defensive and they don't like my suggestion of meeting a professional psychological counselor. They're not even able to discriminate between a psychiatrist and a psychologist. So we need to create awareness from the basic levels. As regards to your question, what is the percentage of people who will need psychological care? I would say, the gist of the treatment here is before, during, and after. So I think all of the patients who are coming to fertility treatment, the very fact they're stepping into the clinic, whether it is for a basic treatment or whether it is a sexual dysfunction, they're just recently married and they are having vaginismus, they're not able to, consummate the marriage at all, or whether it is because of the erectile dysfunction in the male and they're not even able to attempt the first step at all. So to the basic treatments to advanced treatment, there's some amount of stress is there in all patients. And as clinicians, we have the onus to have detailed discussion, individually and then combine together and then, address their needs from the very beginning. Then, we can, slowly, take them through the psychological counseling help and everything. So I think most of our patients needs that level of comfort. And as clinicians, we should ask directed questions to them. We should make them feel more comfortable to answer all these questions, which is perceived, as a taboo to talk about. And what I generally feel, when they're given their space and privacy to answer, they open up. So sometimes I can understand their body language, and I will say, if a fertility nurse or somebody is there in my room, I would, ask them to wait outside, and I will have a one-to-one discussion with the couple, and that thereby they're able to, open up their fears and anxieties related to the issues.
Yeah. So absolutely, I guess like what you pointed out, the privacy and that rapport with the clinician matters a lot. And I guess that is like the pathway or gateway to, to help them acknowledge and assist them for the future referrals. So I'm also curious to understand that at what, because you were talking about, before, during, and after the treatment. So is there any phase that is specific that where you found that, the stage they need more of psychological care, psychosocial care?
We would talk about this. Could we finish your presentation and then
Sure,
we
sure, 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 sure.
discussion? Chitra, may I request you to please share Ms. Purnima Madam's CD, please? Yeah, so a warm welcome to our esteemed guest here. She is Ms. Purnima Mahindru. She is a consultant clinical psychologist and psychotherapist and perinatal psychologist. The Green Oak Initiative, Community Mental Health Center, Bangalore, India. She's joined us today. She's an MPhil of clinical psychology from Kastuba Medical College, Manipal. She's got a decade of experience working in the field of clinical psychology. She's worked as a junior consultant in Enhance, Bangalore. She's completed a training course in mentalization-based treatment for borderline personality disorders, and her areas of interest include preconception, pregnancy, postpartum, and mother and infant bonding disorders. So we are very happy to have you here and would request you to please address us in the next.
Yeah, thank you, Dr. Vasundhara, for introduction. So I'll be just sharing my screen. Hi, good morning, all of you. So I've been working in this field of IVF since now almost 5, 6 years, and it was great to hear Dr. Vasundhara talking about psychosocial care, and I completely agree with Dr. Vasundhara that social care is of utmost importance throughout the phase of when the couple even decide to conceive through ART or through other means, and it becomes really important to take care of their mental health and psychological challenges, because all of us are aware that how it is associated with the stress levels, and how stress levels is associated with fertility. So like I can talk about Indian scenario, like conception and pregnancy is considered as a strong foundation of any kind of marital relationship, and this common occurring psychological disorders along with the infertility that has come across as anxiety, depression, and stress. And it's alarming to see that stress of infertility treatment has been ranked second to that involving the death of a family member or any couple undergoing divorce. Um, so the population who is going through infertility treatment is at high risk of developing psychiatric disorders. And because of the psychological factors which Dr. Vasundhara had talked about, lead to a lot of early dropouts. Prenatal maternal stress, if not like screened, or if it's not handled well, they are negatively related to the outcome of pregnancy and subsequently developmental health of the children. It's also found it's not only during the phase of the ART, but also the chronic stress acts as a deterrent. So biologically, if we have to see, right, like chronic stress actually sensitizes HPA axis activation, which again lead to HPG axis repression, which impacts the female reproductive tract, which actually in effect affects the fertility rate. And even if the mother gets pregnant, like during the phase of pregnancy, if the anxiety or the stress levels are not taken care of, it also impacts the fetal programming, which further impacts the development of the child. So basically, not only the stress that is going through during the ART process, but also the vulnerabilities or the chronic stress has to be handled during the psychological care of the mother or the couple. Now, as Dr. Vasundhara was also mentioning, that what could be the stress factors in ART? So initially, because when any female is going through the ART process, so preparation is required. They have to go through dietary changes, they have to go through lifestyle changes. There are a lot of hormonal injections that they have to take in order to make ART process successful, and that doesn't come easily because they are following a certain diet, and then suddenly that there has to be a certain changes that have to be made, which takes a lot of their energy, and a lot of stress is induced there even during the process. What has been seen that multiple failures of IVF lead to a lot of anxiety and depression. For example, like if the first or second attempt is a failure, there is a lot of dilemma of going towards the third cycle. There's a lot of anxiety. Even let's say they conceive, the whole 9 months is full of stress because it's a precious child and they are worried that if they might lose it. Even the waiting period, for example, when the embryo transplant has happened until the time they get the pregnancy report, the waiting period is considered to be the highest anxiety period, and for not only for mothers but for the both the for the couple. Third is donor. There could be times when female's eggs are not good enough and there is a donor egg, and same goes with the father. Although we end up psychoeducating them about what could be the repercussions or how the looks or how the genetics can be different, but it also but there are many times, especially in my clinical experience, I have seen a lot of clients when they are end up feeling the child when they are in the second or third trimester, then it kicks in, oh, it's not my child. What might happen? What if the child doesn't look like me? Moreover, during the postpartum period, like I can give you an example of one of my client where she was pretty happy during the pregnancy. Unfortunately, she ended up losing one of the twin, but the actual anxiety kicked in and she almost had postpartum depression when the family members started telling that, oh, the child doesn't look like you. There was a lot of guilt, there was a lot of self criticality, there was a lot of self blame, which led to a lot of anxiety, lack of mother infant bond. So, that itself can cause a lot of psychological challenge in the mother or the father both. Even for example, when if father has infertility related issues and there has to be a semen donor, that itself can create a lot of that a lack of self-worth or lowered self-esteem in the father, where they end up questioning their um, they end up questioning themselves, they end up questioning their ability. That also leads to a lot of psychological challenges. The whole procedure of ART, as I was telling, there's like in terms of the care they have to take care of, the procedures, invasive, non-invasive procedures they have to go through, that almost uh, either shatter their self-image or leads to a lot of anxiety. Legal processes that are involved. So let's say if ART doesn't actually, if IUI or IVF doesn't work, then if they even have to figure out the surrogacy or adoption, it itself can be quite taxing because it's not easy to go through that process. B, there is a lot of they have to prove, like especially in surrogacy because of the newly formed laws. So they have to prove that there are certain procedures which was not helpful for them. And as we all know, adoption waiting period itself is 2 years. So the waiting itself for adoption can be quite stressful. As Dr. Vasundhara also mentioned about financial burden, and that actually is one of the major causes where there's a high attrition rate, especially after the first or the second unsuccessful attempt, when they feel that they end up losing hope and they are not able to fund themselves, where either they have to borrow money from others or something like that, and then that actually adds to their psychological burden. Individual and social factors. So individual factors could be a lot of pre-morbid kind of personality, where especially mothers are attaching their individuality, their identity with the concept of motherhood. And the first failure or the second failure itself can be quite devastating. Um, who are mothers who are females or males who are have pre-existing heightened anxiety, they are more vulnerable for developing anxiety or depression during this phase. Social factors. Although there is a lot of awareness about ART now, however, it's still considered as a taboo. So it's a very hush-hush process that itself can add to the already existing stress, which again can lead to a bigger psychiatric or psychological issue. Pre-existing psychological challenges, it could be many, like if we talk about, let's say, when we're talking about sexual dysfunction, if we talked about vaginismus itself is a concern. And if the mother has to go through the whole ART process, there is a high chance of them encountering obstetric trauma. If they have a history of sexual trauma, they are quite vulnerable during the pregnancy and postpartum period, and the ART process can become really challenging for them. And considering these risk factor, it can have a lot of emotional effects on both the parents. As I was mentioning, there can be a lot of anxiety, depression, grief, or despair of not being able to conceive in the first go. If not able to conceive at first go naturally, then unsuccessful attempts during ART, that can lead to a lot of grief. There can be a lot of shock and denial, and a lot of frustration and anger, not towards only themselves, but it could be towards the husband. And it can also lead to a lot of marital discord, because what has been noticed in terms of psychological issues, that there's a lot of blame game that ends up, like either in terms of support, or in terms of not doing enough, or in terms of finances, or in terms of being pressured to go through this. One of the most important thing that what I have seen and what even literature says is, like, when we talk about females, as I was telling, that there is a lot of identity formation around the concept of motherhood. There is a constant feeling of loss of control. Like, they feel that it's not in their hands, and their body is not under their control. So they usually end up feeling unsafe, and they contemplate a very devastating future. And it directly impacts on their self-esteem, identity, and how the world views them. So uh, when we talk about females in terms of, like, the body image and all that stuff, so there are three things that ends up impacting during this course. One is body, where they feel that they are objected to medical treatment, be it invasive, be it non-invasive, even if the infertility is because of the husband. That causes a lot of stress to them. Their identity is jeopardized, because there's a lot of identity confusion. There is a lot of, which again leads to stress, social isolation, withdrawal, frustration, and a lot of conflicts in the interpersonal relationship. Emotionally, it is very difficult for them to cope with the physical pain that they have to go through ART. As I was telling about the grief and despair after failed treatment cycles, and anxiety about, because uh, like, conventionally, what I have seen around the cultural aspect, like, where their marriage is at stake if they're unable to conceive, so that impacts a lot of their self-esteem, their identity issues, and how the world views them. uh, um, and eventually, there are times when it seems during the postpartum period, because they have to go through this amount of trauma, there's a sense of loss of bond with the child. I can give you an example of one of the clients which I saw, where she underwent around 4 to 5 cycle of failed attempts, and the whole procedure was so traumatic for her, that eventually, when there was a sixth attempt and she actually conceived, but it was a very, very, very difficult delivery for her. Like, she refused to go through the to the OT, and she didn't. And during the postpartum period, there was a full-fledged postpartum depression where she was not able to bond with the child, where she felt that it's a liability. She shouldn't have gotten through this process. So there are a lot of these negative cognitions happen. So I'm not saying that it happens with everyone, but obviously there is a vulnerability that we need to tackle, and which can be manifested in these kind of ways. Now, when we talk about role of psychological intervention, so role of psychological interventions, when we talk about psychoeducating, when we talk about when they take the plunge of going through the ART to enhance the communication between the couples. So as Dr. Vasundhara was mentioning, in terms of like how, as a clinician, you can talk to them. It's best happened in private, one-to-one, so you are able to understand the kind of grief they are going through. Is it a decision of only one person, or it is a decision of both the couple? And if are both of them okay with continuing even after unsuccessful attempts, or is one is being pressurized and other is denying that for various reasons? Second is to address their grief, how their grief of either not to conceive naturally or of unsuccessful attempts is addressed. Because if it's not addressed properly, even if they happen to conceive in the near future, that can have a lot of repercussions during that pregnancy. Um, it's always recommended to start early to help them with acceptance of infertility. That starts when even they come for the first consultation with the infertility specialist, which entails what the process would look like, what all things they can expect, what all failures they can expect, and is there even a chance that they cannot conceive naturally? So all these kind of conversations need to happen before they get into ART process. Psychological care can also aid in developing coping mechanisms and decision making. Um, and as a psychologist, or in terms of psychosocial care, we don't give advice what they should do. It's more like helping them coping with their emotions, and facilitating them to take decisions. To deal with pre-existing psychological trauma, as I was telling you, like if anyone is subjected to, let's say, sexual abuse, or if there is interpartner violence that's going on between the couple, and then they're coming for the ART, so all those pre-existing psychological issues need to be addressed, else either it can lead to repercussions during the postpartum period, or even during the pregnancy, or in the mother-infant bond. Psychological help is pertinent, as like I agree with Dr. Vasudha, like during ART, during ART process, and post ART. So how it would look like. So when they are contemplating, so assessment of preparedness. So personally, how I do is like like not only during the ART process, but we have this something a module. What we follow is preconception counseling, especially for the couples who are in dilemma, who are not sure if they want to go through even the pregnancy. So what the module is, like, one session is held with the mother alone. To be mother alone, one session is held to be father alone, and the third session is a joint session, so that we are able to understand each of their perspectives, we are able to understand each of their emotional health, and then it comes as a joint discussion. Trauma has to be dealt before they get through ART process. It could be, as I was telling you, it could be sexual abuse, it could be vaginismus, it could be previous history of miscarriages, it could be previous unsuccessful attempts, it could be their trauma with the relationship, or the trauma with childhood trauma. So all these things have to be addressed before they get ready for the ART process. Psychoeducation, again, like do's and don'ts, pros and cons, and having a better understanding of what could be the repercussion, and what could be the outcomes they can expect. So middle phase is during when they have conceived, and when or the embryo has been transferred. So it's more on focus on short-term intervention. So pregnancy or when they are waiting for the period uh, to get the result, that is not the phase where the trauma has to be healed. So it's a very short-term intervention where we carry out more of anxiety management, stress management, depression management. In this case, it could also be a time where if things it's amounting to a disorder of a moderate and severe severity. Again, this could be a time where a consultation from the psychiatrist can be done, because there are now a lot of safe medications, safe psychotropics are available. So a collaborative approach will be helpful. So when I talk about multidisciplinary approach, it's not only about obstetrician, psychiatrist, or psychologist, but also the nursing staff. So there are a lot of clients I get from various places where they say that the way the news that was uh, about the test results was told to them, right? Then it has to be communicated in a very a calmer manner. A proper one-to-one discussion has to happen. It should not be like, is it a success or a failure? Like there a proper time has to be given so that they can process it or they can grieve over it. Because even for the matter of fact, the nursing staff has to be uh, skilled for how they should be communicating with the clients who are going through ART, because that matters a lot in terms of them either continuing or dropping out, or giving them hope that okay, probably the next the cycle would be successful. Postpartum phase, as I was telling earlier, also that working through postpartum adjustment is of utmost importance. It could be because of the multiple pregnancy that the postpartum adjustment can be maladjusted, or because of obstetric trauma, or because of the factor of when they feel that it was either the egg or the semen was of the donor person. So all these things has to be discussed or has to be taken care in terms of psychological intervention during the postpartum period, because the mother has gone through a lot of these struggles during this ART process. So we have to be very, very careful in terms of assessing and assisting them to develop mother infant bond. Because if mother is anxious, mother is depressed during this phase, and mother is still preoccupied with what has happened with her, the infant mother infant bond would not develop, which eventually will hamper the development, either cognitive, emotional, and social development of the infant. So it's an elongated longitudinal psychosocial care rather than just a band-aid effect. So from my end, the takeaway message is that going through ART is a psychologically tiring and difficult process. So we need to acknowledge, assess, and assist the vulnerable population. So working on all psychological challenges or everyone's psychological challenges is not possible. But if we are able to see that who will be benefited more, it can aid in the maternal mental health. It can positively impact fertility, and it can also further aid development of the infant. Key is not to take stress. Like normally we'll say, okay, don't take stress, which is not possible. Stress is inevitable because of whatever things that any couple goes through. But what we need to focus is how the stress can be managed effectively. Thank you. Dr. Vasundhara, I'm unable to hear you.
Audible now?
Yes.
Sorry for that interruption.
Mhm.
It was a wonderful session with Purnima with your practical, day-to-day case-based discussions. So definitely, it is very important to understand all these aspects so that we can, address these issues in our day-to-day practice. In your sessions, really appreciate, your practical tips. However, what I really notice is nowadays the access to information is too much. Like if you Google anything and everything, you get information. So I think, though the information is available all around, authenticated information, right information is very important as well to reduce their anxiety levels or keep their anxiety levels under place. Like any patient who would come would have already browsed about the procedures or would have had experiences. For example, if I talk about endometriosis or if I talk about adenomyosis, and if you access the internet, there can be stuff from basic to advanced, and it can really scare their psyche out before even starting their treatment journey. So what I would really tell my patients is to avoid internet-based tools to keep their anxiety levels under check. For this, I do regular teaching in my OPD. I give them visuals or show them charts, show them some scientific evidence, what is available, and also their individualist chances. Like endometriosis may not be the same in every individual. So it can be stage 1 in somebody, it can be stage 4 in somebody. So it need not be the same for every patient who is having the same disease process. So I think it is very important for us to counsel our patients on access to knowledge and correct knowledge to keep their psychological stress levels under place. Also, recently, what I'm seeing in my OPD is there are a lot of patients who come premarital evaluation of their, fertility status. Be it a man who wants to know whether his semen parameters are normal, or a woman who is going through a fertility process. She already knows she has PCOS or irregular periods, so she wants to be sure whether her fertility level is okay. This apart, this is a good thing, because they want to be aware. But there is a lot of stress as well. Recently I had a patient in my OPD who came for a routine checkup saying that, I want to know, I'm getting married in 2 months' time, I want to know if everything is all right. I said, what brings you here? She said, my mother-in-law to be. She was talking to her, and then she said last month she had her period 2 times in the month. So her mother-in-law was like, why don't you have a check whether everything is all right with your uterus and with your fertility. We are going to get married soon. And she started breaking down and crying in my OPD. She was not even into the marriage. So I had to reassure her, and because of the so much of society pressure and so many things, I think it is very vital for us to give them that space and give them that reassurance when they come. So it is not as simple as their premarital check or their fertility. So there is a lot of things involved even with the whole process.
Right,
So
yeah. So I absolutely agree. I guess like especially because you guys are the first contact of them, and if they are feeling comfortable with you, and if you are able to give them that space to talk about it and to provide that adequate information, that gives them that confidence to take the psychosocial care further as well.
So I just wanted to, understand from you that, how should we increase the acceptance of this, psychological counseling, and, for this, how though we are creating some awareness, but it's still not really reaching, and their acceptance levels is still on the lower side. And also, probably, if you could tell, a couple is being referred to you, what will be their first consultation like? They should not be really worried, they're going for some big therapy or they're having a pre-existing disorder, that's why they're meeting you. So, just to understand what would be their first consultation with the psychological counselor would be.
So, the first consultation of with any psychologist would look like where we try to understand their history. So basically, it's not a very kind of an interrogative, or we are not trying to say what disorder they have. right? We are trying to understand what is causing that anxiety, what is causing that depression. So basically, the first consultation is always a form of assessment which helps them give the clarity what's happening with them. So especially I as a therapist, what I do is I by the end of the session I give them a formulation. What, like for example, what could be the triggering factors for them? What could be the protective factors for them? What could be their maintaining factors why they are having that anxiety? And how it's, and again, the aim is not to tell who has to be blamed for. So that's not how the assessment or any psychology session looks like. It is more like a very collaborative approach where we seek their expectations from the space and also help, we give them what our understanding about the whole situation is. So coming to a psychologist doesn't mean that they have a psychiatric disorder per se, but if they have even a little amount of anxiety which can be managed, so that the pregnancy or the whole process goes seamless. So that is the way at least I handle in a very non-critical, non-judgmental kind of a space.
So at the first consultation, you probably give them that comfort zone first.
Yes.
That is very, very important.
Yes.
And also, what information you need from the clinician about the client who are referred to you, so that it is easier for you to, start a conversation with the couple.
Right. So basically, not a basic brief why they feel the need that they should have a psychological assessment or a psychological care, and what as a clinician you felt that what could be happening with them, your impression. So that is more than enough to take it forward from there.
Yeah. Because, as a clinician, it's better that I connect with you and tell their background, because sometimes they will open up with me, and then, it will take some time to establish a rapport with the psychologist to open up everything. So probably,
Right.
if I tell you, you can probably, ask them certain leading questions in those things, and then give them the comfort zone so that they speak up.
Right. So I completely agree because that also helps in a very collaborative care. And collaborative care is makes the client also feel heard and makes them feel safe enough to go through this process.
Absolutely. And also, like rightly you said, like, collaborative care. Like, I was just wondering, like, when we were pondering how to create awareness about seeking psychological help, I think it is collaborative care that can help. For
Yes.
example, if correct me if I'm wrong, I don't know whether patients directly approach a psychological counselor themselves, or it is more through the clinician or somebody else who is suggesting them to go and meet. So the proportion of referrals will be slightly higher in Indian scenario rather than they approaching the psychologist themselves. So I feel that we should be connected with the psychologist and vice versa, so that the referrals are more and our patients are like little reducing their stress levels when they come.
I completely agree because I guess in my patient load, hardly 10 or 20% are self-referrals. Majority of the referrals are either through a gynecologist or during the postpartum period through a pediatrician or their OBG also during the postpartum period or through and through their friend who has gone through that. So it's never like it's unfortunate that the awareness is that low, and it also depends from city to city. So the referral pool is higher in tier one cities as compared to tier two, tier three cities because again, the stigma attached to it, again, an awareness attached to it. So what we have done in our organization is we have stuck infographics on the notice board where even if it's not, they are not going through, suppose for example some patient's family is waiting in the waiting area, so they are able to see what are the infographics stuck on the notice board and everything, and then that's a smaller step to create awareness. So that's how we do.
Yeah. So I think in future probably we could look at collaboration between fertility specialists or gynecologists with the psychologists, so that our patients are much safer. When a patient is with me for 2 years, 3 years, and they have already gained my confidence, right? So if I say, they have the trust that I'm doing something for their well-being, so that's very,
Yes.
very important. There's one very important question in the chat box which says that, are we having any tests to find the level of stress?
So
Can
and
we
yeah.
detect that and refer to you, or when we send to you, do you do any particular
So
test?
we don't do, so again, the gold standard is clinical interview. right? So stress is very subjective in nature. What might be stressful for you might not be stressful for me. So there is no quantitative measure of stress, but what we can assess is what could be causing the stressors. But as a clinician, I guess one of the things what we tell a lot of health practitioners, gynecology pediatricians. So the what you can guys can follow Woolly questions. So it's like a two question kind of a test where you just ask like uh, have they been feeling helpless or hopeless since lately, or have they observed their mood to be dipping since past couple of weeks. So these are the two questions which you can ask, and that could give you an idea if the person is stressed or not, but there is no quantitative measure of stress per se.
It's very, you're very right. We can't really quantitatively measure stress. For example, I can tell you there is a couple who is going through an IVF treatment, and after one failed IVF treatment, they are, into a stress disorder or a depressive disorder. But there is another couple who has had 3, 4 cycles of IVF failures, and they want to be persistent and do more and more until they achieve the success rate. So their mental strength to handle one failure and multiple failures, I think it varies across individuals and their surrounding background. I think
Yeah.
that is very important. And when you do counseling for these couples, do you also involve the family members into this sessions, and is that helpful for you and for the patients?
So I definitely involve at least husband in terms of assessment per se, for the history and what their observations had been, but not in the whole therapy process. So there are multiple reasons. One is like the kind of trust and trust the mother or the father is coming to me for the individual therapy. But if there is a requirement for, let's say, couples therapy to resolve the marital discord, or need for family therapy. So in the team, we have dedicated couple therapists and family therapists. So that kind of care is given to them. So that care is not neglected, but we make it sure that this individual safe space is for a specific person who's coming for individual therapy, and others are doing whatever they require to do with the couple or the family.
Yeah, because see, many times, sometimes we as clinicians are, confronted in certain, situations which are very difficult for us to answer. And there are certain questions like, there will be the couple who will be coming with either the husband's parents or the wife's parents to our room, sometimes together as well. So mostly what happens is there will be questions like, is there a problem with the woman or is there a problem with the man? Now, we cannot really address this issue as a one-sided thing, though we know the reason for going for an IVF could be an unexplained factor, or it could be because of a male factor, or it could be because of a female factor. So if somebody, if, in a family member, or if somebody is coming and asking us, is it because of the man or the woman? I think we have to take this as the entire unit. So even if it is an unexplained infertility and if they're going for an IVF, the chances of a live birth is 2 to 40%. So another like 50 to 60% is a gray area. We really don't know once the egg and the sperm meets and forms an embryo. Once we put it in the uterus, not all embryos really implant. So we really can't predict which is the reason for not implanting or not this thing. So there has been a lot of instances where certain things like this have been answered, and there has been a marital discord and the couple is really separated. There has been family disputes. I think it is the onus on the clinician to kind of talk to the family members collectively and tell them that the couple is a unit by themselves. They are not an individual. And I think once they're married, they have to handhold each other and move in this fertility journey. That's extremely very
So
important.
absolutely, it has to be a joint decision. So a lot of stress actually comes up when the onus is either on the male or the female, right? So it has to be a collaborative thing. It has to be a decision. And plus, if they are not able to do that, obviously, couples therapy is required. If they are feeling that they are not ready, but the family is pressurizing, then family therapy is required. So based on where the stressor is, so that can be taken care in terms of psychosocial care.
So, the common, like, we were discussing this point again and again. Post embryo transfer, the 2 weeks wait period is the maximum, the stress level fluctuates. they imagine whether this is a symptom of pregnancy or this is not, or if they have a pain in the abdomen, they think their period is going to come, the treatment is failed. So, what is your advice, in this wait period? What should they practice and how can they keep their stress levels under check? So, what do you advise?
So again, depends upon if it's anxiety, it's a very short-term anxiety. So then certain relaxation techniques, like, what we help them do is either like deep breathing or yoga, meditation, and everything. But at the same time, the communication between the partners. So it should not be just brewing, the stress is brewing only in the female's head, but there has to be communication either with between the partners, or they should be able to identify a support system there where they can talk. Even the in-house counselors, like now all infertility clinics have counselors. So in-house counselors can be made available during that period where they can come for the sessions and talk about their fears, their stressors, everything. That can be really helpful. At the same time, again, it is a stressful period, so we cannot just say don't take stress. But what we really need to help them is how they can manage the stress, how they can be more mindful about what they can do right now to manage their stress. Because what happens during this is it's more about anxiety about anxiety. So it's there it has various layers. For example, when they say that, okay, if I take too much stress, the fertilization will not happen, right? So they are anxious about even when they are taking stress. So when they're anxious, so that also has, but that can be only dealt with when they are meeting the counselors. But on their own, they can have a good support system. They don't need to brew inside them. They can journal. They can do yoga. They can do relaxation techniques. It's a plethora of relaxation techniques which can they adopt. So those are the things that they can do during the 21-day waiting period.
So I think, as you said, what we could do is like, even before their embryo transfer, the couple has to be, sensitized about this wait period, how anxious it can be, what they can do to reduce the anxiety levels, what are the breathing techniques or whatever journaling you are mentioning. And obviously, like, the core is to keep their, reality levels under check. Like, we have been sensitizing them about the realistic chances of conception. But having said that, you give them a 20% success rate, 40% success rate, all this is totally forgotten once the embryo transfer is done.
Yes.
They perceive themselves to be, as, mothers, and the treatment is this thing. So we need to, keep, it is an ongoing process. And what I would say is like during the 2 weeks wait period, you practice all these breathing techniques and listening. And I also tell the patients that, the husbands have to be a little bit, more involved in that 2 week wait period, empathize with them or be with them in the journey. And whenever their anxiety levels are going up, I think the family members have to step in and give them their comfort levels. And also it is, I tell them that, okay, whether it's 20% or 40%, the embryo is now inside you. So let us give a stress-free environment for the embryo, and then, leave the outcome to whatever the supernatural power is. So we have done
Right.
it, and we should, take
Right,
it.
absolutely. So there are times what happens is even when we educate, what partners end up doing is they are dismissive. They said, okay, don't take stress. You are just thinking, overthinking, and everything. So that dismissal itself can be stressful. So we really need to, make sure that both the partners are equally understanding that it is going to be a stressful period and they have to be there for each other and to be receptive out whenever each of them wants to speak about it.
And more importantly, in the 2 weeks period, we tell our patients that we in the clinic, our fertility team and staff are accessible always for their doubts and clarity. So
Yes.
always, whether it's related to the tablet, whether it is related to the food or any symptoms that they're experiencing that is causing anxiety, they can always reach out to us and get that reassurance. That is also very important from the clinic.
And that's a very nice point, because sometimes what happens, one of the things that they reach out is reassurance to the healthcare team, right? So even the front desk people who are answering their calls, so they also need to be trained in how to communicate with them, how to reassure them, because that itself can be very therapeutic for them.
Anything that you would want to
So yeah, like I because I as I work in a very in a psychiatry heavy organization, like although we collaborate with the gynecologist, I was just curious to understand that how do you see this infertility process for the couples? Like at what stage you find that they require this kind of psychosocial care the most?
I think the most important vulnerable periods are like, definitely after one failure. I'm just highlighting the key things. They need it throughout, but the most important phase is after a treatment failure. The second thing is they might, have acceptance issue to a donor program. Though they know that the cells are exhausted, they'll not be able to go through their own this thing, but it is a biological inherent feeling of a woman to have self gametes. So I think we need to sit and talk to them, counsel them what is age-related physiology that is happening and that cannot be reversed. Keep talking at multiple sessions, understand their needs. So I have two sets of clients. One, a patient who is 42, 43, who knows that her fertility level is very low and we cannot achieve a successful pregnancy out of her own eggs, and they're being counseled appropriately whether they want to attempt, which is just going to be an attempt, one or two eggs or maybe nothing, or resort to donor eggs or adoption. So we have this clear-cut decisions even before 3 to 4 months before starting any of this process, because this involves emotional and financial concerns. So there is one group of patients who tell me, the doctor, that we are not for donor programs at all. Both the husband and wife are there in the discussion. We know that my fertility level is very low. I understand my age related decline, so we will attempt 1 or 2 cycles of our self gametes. If it's not working, we are going to let it be. We're not even planning adoption. There are other individuals who will say we will attempt once. If it doesn't happen, then we will go for a donor case, understanding the financial implications of doing self and donor. There'll be the other person who will be saying that we would want to go for donor. So these discussions has to happen, and documented and again inquired before they start their treatment journey. So I think these are very important. And second thing is when they go for a donor gamete, it has to be the psychological acceptance of the couple. That is very important. Because right now they are in a phase that, sometimes they say that, doctor, I want a child. I don't care whether it's self or donor, but then it is a very temporary feeling. There can be a lot of repercussions 10 years later, 15 years later, so many things. Sometimes the husband would say that, I don't want my wife to know that we are going through a donor process or vice versa. But I would say, I would sit and talk to them. I would say there are certain concerns and certain legal implications to this, and also psychological implications to keep their marital harmony for a long number of years. It is very important. In this process, there can be some attrition of cases for me, which doesn't really matter. But I think this is very, very important, clear, transparent communications to the patient and making them aware that, why they need going for a donor gamete and whether they're able to accept it. And if they're having a dilemma, I think that is the point where I would say definitely they would need counseling. The other aspect is definitely when they're opting for surrogacy. It is a big challenge for them to, have surrogacy. Both the surrogate mother and the biological parents should definitely have psychological counseling. Again, obviously, adoption, that is a different this thing. And then it is the onus of us to say when they should stop treatment as well. We cannot just endlessly recommend treatments and treatments and treatments. So it is definitely a responsibility, a collective responsibility for both of us to say, this is the end of the road and you should focus on other things in your life. That's very, very important. And there, the psychological intervention is very, very important. The other things which I feel an intervention is important is in patients where there is recurrent implantation failure or unexplained infertility. They're really worried, unexplained is like, unexplained. They don't know. They feel everything is normal and why I'm not getting pregnant. Sometimes they come and tell me, doctor, you please tell me a reason, then we are happy. But then, I will tell them that, if I find a reason, suppose there is a severe male factor or suppose there is a premature ovarian failure, it's going to be much more critical to accept and there can be no cure to that diagnosis. In unexplained, yes, there is an uncertainty. We don't know what is happening, but at least you have a decent chance in IVF or HC treatment. So I think those are that unexplained category, sometimes they literally not able to come to terms with unexplained. Everything is normal. Everything is normal. Why I'm not conceiving? That's one group. Recurrent implantation failure, again, it is very difficult for us to handle. It is patients go into a denial phase. They've attempted everything possible. Their embryos are genetically normal. Their uterus is beautiful. We as doctors don't know why the embryo is not implanting. There is no reason that I can really identify. Though the true implantation, recurrent implantation failure is only 2 to 3%, and when we identify those 2 to 3% of our clients, it is very difficult for them to accept that. So I think at that point, definite, acceptance or talking to them, professional help from the counselors are really mandatory. So I think these are the stages where I feel, we should push these patients for psychological care and counseling.
Yeah. But that was pretty helpful, Dr. Vasundhara, knowing those stages, right? Because I guess, um, as I was telling, collaborative approach, right? Like, for example, what you were talking about surrogacy, about the preparation. So, even we as psychologists need to be aware about all these processes, about the legalities and all, because how they can add to the stress and how a donor, phase can add to the stress. So, yeah, so that was pretty helpful in terms of understanding what could be the stages
So
there.
there has to be just like how there is a super specialty to say, we finish our MD gynec and then specialize
Mm.
in reproductive medicine. I think, instead of a general psychology, the psychologists also have to specialize into fertility related counseling, and they should understand what this recurrent implantation failure is, what is unexplained infertility,
Absolutely.
so that they can deliver personalized care to our patients. No, I think that is very,
Right.
very.
No, no, I absolutely agree. And I think it's quite unfortunate in India specifically, right? Like we don't have that kind of subject material which is taught to us during masters. It's all that we learned with doing our own specific courses. But I guess that would be necessary, and hopefully like we are able to figure it out how we can educate the counselors, because I guess this phase is really, yeah,
Collaborative thing, so that we can empower the psychologists to
yes.
do a wonderful job, for patient empowerment. That's very
Right,
important.
right. And for the good effectiveness of the whole process as well. Right. But yeah, like that was pretty helpful. But like I'll ask you one last question, which I was thinking. So as you were asking me also, like, how the assessment goes. So do you have any pointers, or how do you what makes you feel the need that this is the time they should be referred out, like to the psychiatrist or the psychotherapist? Are there like how do you identify that?
History,
Mm.
we do a detailed history taking exercise. The first, a new patient really takes like, close to half an hour to 45 minutes, in the OPD. So I talk to them about their sleep pattern, about their work, culture, how stressful they are at home and work, how is their sexual life, how is their time together, whether they have time to bond together, whether they're living in a nuclear family or they are having a joint family. So a lot of this discussion happens, and some people start talking to me like there's a lot of pressure from their family, and sometimes they just live husband and wife, but then from their hometown there's always a call that what's happening, are you going for consultation. There's a lot of pressure from the family to conceive immediately. So a lot of these things we know. I kind of address these things in the first level itself, and I put my notes in the file that there is a potential possibility for this couple to have future counseling. The second important thing, even in the first session itself, I would know if the patient is coming and they're, first time they're knowing that they are having zero sperm count or, azoospermia, it is very difficult for them to really understand they're newly married, or the vice versa. They are just married and the wife is having premature ovarian insufficiency and they have to go for a donor egg immediately. So first of all, it's a common thing to think that couple is newly married and they wouldn't seek fertility help for 1 year, and after that only they would want to approach. And it is a big blow to them, to understand that it's the zero sperm count or there's premature ovarian insufficiency. So these are like, straightforward things. I talk to them a lot, but then once I talk to them, I also tell them that probably, I'm not really professional in, delivering my, counseling in terms of psychological and psychosocial aspects. And I would say that, separate sessions with the professionals will definitely help them to accept the treatment process and move on.
Yeah.
So I make my initial notes based on their history, their lifestyle, and their stress levels, sleep pattern. So there will be notes in my file so that I can refer them little later on. But I will also really be happy if we could have some triaging kind of a thing, because my talking to the patients the first visit, after that when the OPD is very heavy, I might not be able to give the consistent time to that particular patient, which is important. Now they go and get injections from the staff nurse. Post embryo transfer, they are in the recovery room for 3-4 hours. There will be interaction with the other staff members or the support staff there. How to empower our staff, you know, they can also triage people and say, ma'am, they are with you, this is what it is. And, help us more, in this aspect is also something that we should really.
Yeah. No, absolutely. I guess the triaging process becomes really important in this kind of a process where obviously the consistent timing is not available and the other staff comes as a support system. So I guess introducing triaging will also help you understand their mental health concerns. Right.
So, I think we would, come up with much more sessions in future. Thank you so much for your time.
No, it was my pleasure. Thank you, Dr. Vasundhara, for inviting me here. Like it was a good, enriching session for me as well, knowing your viewpoints and how your practice goes. So, thank you so much.
I would like to extend my heartfelt, sincere thanks to the entire team of Shield Pharma, Mr. Balaji, the president of Shield, and Chitrakala, who has done a wonderful job in bringing this webinar together. Thank you so much. Thank you.
Thank you, madam. Thanks a lot.
Thank you.
Thank you.
Thank you, ma'am. Thank you,
Thank
sir.
you.